Welcome to the Deep Dive, where we peel back the layers on complex topics to get to what really matters. Today, we're diving into a foundational concept in medicine that's incredibly important, but can feel like navigating a maze: intestinal obstruction.
And we're pulling our insights directly from a heavyweight source, Bailey and Love's Short Practice of Surgery. It's a classic text, comprehensive and quite detailed.
Definitely. So our mission for this deep dive is to guide you through the core concepts from these pages. We want you to understand what intestinal obstruction actually is, why it happens, how patients present, and, the main approaches doctors use to figure it out and fix it.
And we're sticking strictly to the material in the source. It's a really rich text.
It is. Okay, let's unpack this. Right away, the source gives us a really clear way to think about intestinal obstruction. It splits it into two big, distinct categories.
That's right. You have dynamic obstruction and adynamic obstruction, the key difference. Well, in dynamic obstruction, there's a physical block, and the bowel's muscle contractions, peristalsis, they're still working, trying to push things past that block.
Got it. So the muscle is actively trying to overcome an obstacle. Makes sense. What about adynamic?
With adynamic, there's usually no physical blockage. The problem is that peristalsis, the gut's movement, is either significantly reduced or completely absent. The traffic is just stopped because the engines aren't running, so to speak.
Yeah, that analogy works well. The source gives us examples. Dynamic is your classic mechanical obstruction.
Right.
And adynamic includes things like paralytic ileus or pseudo-obstruction.
Exactly. Those are the big two families.
Let's zero in on dynamic obstruction first, that mechanical blockage. One of the most common things that physically get in the way.
Okay. The source organizes this really logically by where the blockage is located relative to the bowel wall. It can be intraluminal, meaning something stuck inside the tube itself.
Like what?
Think fecal impaction, hardened stool, foreign body someone might have swallowed, or bezoars. Those are compacted masses, like hair or plant fiber.
I've heard of hairballs in cats, but in people.
Oh, yes. The source mentions trichobezoars from hair and phytobezoars from fiber, often linked to specific habits or sometimes after stomach surgery. And interestingly, they also mention gallstones causing blockage.
Wait, how does a gallstone get into the intestine to cause a blockage? That seems odd.
It does, doesn't it? The source notes that a large gallstone can sometimes erode through the gallbladder wall straight into the duodenum, the first part of the small bowel. Then it travels down until it gets stuck. Often surprisingly far along, the source says about 60 centimeters from the very end of the small bowel.
Wow. And usually in older patients.
Typically seen in elderly patients, yes.
Okay, so that stuff inside the tube, what's next?
Next is intramural, meaning something in the wall of the bowel itself is causing the problem.
Okay, like glee.
This could be a stricture, which is just a narrowing, a malignancy like a tumor growing in the wall, intussusception.
That's the telescoping one, right?
Exactly, where one segment of bowel telescopes into the segment next to it. Or volvulus, which is a twisting of the bowel on itself.
And then finally, extramural, which means something outside the bowel pressing in.
Precisely. And the source highlights the most common culprits here. Bands, or adhesions, which is basically scar tissue, often from previous surgery. Or hernia, where a loop of bowel gets trapped, poking through a weak spot in the abdominal wall.
The source actually gives us numbers for this, right? Showing just how common some of these are, at least in Western countries.
They do. It's quite striking, really.
Yeah.
Adhesions account for about 40% of mechanical obstructions. 40%.
Wow.
Then malignancy and inflammatory conditions like Crohn's disease each cause around 15%, and obstructed hernias make up about 12%.
So that scar tissue from past operations is the single biggest player, by far.
It really is.
40% is huge. Okay, so something is blocked. What happens to the bowel above that blockage, the part where things are backing up?
Right. Well, it starts to dilate or swell up with gas and fluid. Meanwhile, the bowel below the blockage initially keeps working until it empties out, and then it becomes quite empty and collapsed.
And the body tries to fight it initially.
Yeah, your body's first response is to increase peristalsis above the blockage. Those muscle contractions get stronger, trying to push through it.
Like the gut is saying, all right, let's power through this.
Exactly. But if the obstruction isn't cleared, that bowel just keeps stretching, the muscle gets tired, overworked, and eventually the peristalsis weakens significantly. The bowel can become flaccid, almost paralyzed in that section. And the swelling, the distension, isn't just solid stuff backing up. It's also a lot of gas and fluid accumulating.
And the source gets specific about the gas, doesn't it?
It does. You get significant bacterial overgrowth in the stagnant bowel contents above the block. These bacteria produce a lot of gas. After your body absorbs the oxygen and CO2, what's left is mainly nitrogen, making up about 90% of the trapped gas, the source says, plus some rather unpleasant hydrogen sulfide.
Hydrogen sulfide. Sounds about right for stagnant gut contents. Ugh. And then there's the fluid buildup.
Yes, and this is a major contributor to dehydration, a really key point. Think about how much fluid your body normally puts into your digestive system every day. The source mentions roughly 500 milliliters each of saliva, bile, and pancreatic secretions, plus a whole liter of gastric juice over 24 hours.
That's a lot of fluid.
It is. Normally, this all gets absorbed further down, but if the gut is blocked and absorption is slowed or stopped, all that fluid just pools above the blockage.
So you're not only taking less fluid in because you might feel sick or be vomiting,
Right.
but you're effectively losing fluid internally.
Precisely. That fluid is trapped in the bowel lumen. You might be vomiting some of it up. Absorption is poor anyway, and some fluid can even leak or transitate into the peritoneal cavity, the space around the bowel. This leads quickly to dehydration and a loss of vital electrolytes, a major systemic effect.
Okay, that paints a pretty clear picture of the bowel backing up and swelling. But the source introduces a much more dangerous situation: strangulation.
This is the critical part. This is the real emergency. While simple obstruction is serious, it's not immediately life-threatening in the same way that strangulation is. Strangulation means the blood supply to that segment of bowel is cut off. The bowel becomes ischemic, meaning it's not getting enough oxygen, it starts to die.
What causes that blood cutoff? Is it just the twisting or the trapping itself?
The source lists a few ways this can happen. It can be direct pressure from a tight ring, like in a hernia opening, or from a tough adhesion band squeezing the vessels.
Yeah.
It can be the twisting action of a volvulus, or the telescoping of intussusception that kinks the blood vessels in the mesentery, the tissue that holds the bowel and carries its blood supply.
Okay.
Or, and this is important, it can be the sheer pressure built up inside the lumen, especially in a particular type of obstruction called a closed-loop obstruction.
That sounds significant. A closed-loop obstruction. Tell me more.
It is, and it's very prone to strangulation. This happens when a segment of bowel is blocked at both ends. Imagine a loop blocked off. Pressure builds up intensely within that trapped loop. The source gives the classic example of a blockage in the colon, say, from a tumor. When the valve at the beginning of the large bowel, the ileocecal valve, is competent.
Competent meaning it works properly, like a one-way valve.
Exactly. It stops stuff from flowing backward from the colon into the small intestine. So if that valve is competent, pressure can't relieve itself by backing up into the small bowel. It just builds and builds inside the colon, particularly in the cecum, the first part, which has a relatively thin wall compared to the rest. That high pressure can squeeze the blood vessels in the wall itself, cutting off circulation, leading to necrosis, tissue death, and potential rupture.
But if that valve isn't competent, if it lets things back up,
then the colon can decompress somewhat into the small bowel, which reduces the internal pressure buildup in the colon and lessens the risk of strangulation from that specific mechanism. It doesn't eliminate all risk, but it helps.
So the mechanics of how the blood supply is compromised are fascinatingly specific. It's not just one thing.
Not at all. And whether it's direct pressure or internal pressure, the source notes that often the venous return, the blood trying to get out of the bowel wall, is compromised before the arterial supply bringing blood in.
So it gets congested first.
Exactly. Blood can get in, but not easily get out. This causes congestion, swelling within the bowel wall, and then when the arterial supply is finally cut off due to the increasing pressure or the twist tightening, you get hemorrhagic infarction. The tissue essentially dies in a bloody mess. Once the bowel wall loses viability, bacteria and toxins leak out, either into the abdominal cavity or directly into the bloodstream, causing sepsis and systemic illness.
And I imagine how bad this gets depends heavily on how quickly it's recognized and fixed and how much bowel is involved.
Absolutely. Time is critical. The longer the bowel is without blood supply, the worse the damage, the higher the chance of irreversible damage or perforation. Elderly patients, or those with other health conditions, comorbidities, are less able to tolerate the stress of ischemia and sepsis.
And if a lot of bowel is affected?
Even a relatively short segment of dead bowel can cause severe systemic problems from infection and toxins. Extensive involvement can quickly lead to widespread circulatory collapse and shock. It's incredibly serious.
Okay, let's dig into some of those specific types of mechanical obstruction that the source gives special attention to. You mentioned internal hernias, strictures, those boluses, adhesions, intussusception, and volvulus earlier.
Right. Let's take them one by one. Internal hernias are quite rare, thankfully. It's where a loop of bowel gets trapped in an unusual hole or space inside the abdomen. Could be a natural opening or one created by surgery.
Mhm.
The source lists examples like the foramen of Winslow, which is a small opening near the liver and stomach.
And they're dangerous.
Very. The danger here is high because major blood vessels are often right near the edge of these openings in the constriction ring. The source gives a crucial surgical tip. If you find one during surgery, you should try to gently decompress the trapped loop. First, squeeze the contents back before trying to pull the loop out.
Why?
To avoid tearing those vital vessels that might be caught in the ring, relieve the pressure first.
That makes intuitive sense. How about strictures?
Enteric strictures are just narrowings in the bowel wall. The source points out that in the small bowel, common causes are conditions like tuberculosis or Crohn's disease. Less often, maybe a tumor.
And these cause sudden obstruction.
Usually not. Because they tend to develop gradually, the symptoms are often more chronic, or they come and go what the source calls subacute obstruction. Surgically, you might cut out the narrowed section, but for Crohn's, where there might be multiple narrowings, they sometimes do a strictureplasty.
A stricture plate.
Yeah, it's a technique where they cut lengthwise along the stricture and then sew it up sideways. It widens the narrowed segment without actually removing any bowel. Kind of a neat trick, especially if you want to preserve bowel length.
Okay, that is clever. Now, the boluses thing's getting stuck inside. We talked about gallstones.
Yes, that gallstone ileus.
Yeah.
Usually an elderly patient, stone erodes into the duodenum, travels down, gets stuck, often about 60 centimeters from the end of the small bowel. On an X-ray, the source describes a classic combination of signs called Wriggler's triad.
Wriggler's triad, what's in it?
Okay, you see signs of small bowel obstruction, dilated loops, maybe fluid levels. You see air in the bile ducts, which is called pneumobilia. Air got in where the stone eroded out. And you might see the gallstone itself as an unusual shadow on the X-ray.
And seeing all three means it's definitely gallstone ileus.
The source says seeing even two of those three signs together is considered pretty definitive, or pathognomonic in many cases. Though they add a caveat, pneumobilia alone, just air in the bile ducts, is actually quite common after a specific scope procedure called ERCP, which is used to look at bile ducts. So it's the combination that's really suggestive of gallstone ileus.
Got it. The context matters. What about those other boluses you mentioned?
Right. There can be food boluses, especially after stomach surgery, that might affect how food is broken down before it hits the small bowel. High-fiber things like oranges or apples can sometimes be culprits if not chewed well. Then there are the bezoars, trichobezoars from ingested hair, sometimes linked to psychological conditions, and phytobezoars from undigestible plant matter. The source also mentions stercoliths, which are basically very hard, stone-like fecal masses usually found in the colon. And yes, worms.
Are worms causing a blockage?
Specifically, Ascaris lumbricoides, a type of roundworm. They can form a tangled mass and cause obstruction, especially in children in tropical regions. The source even notes you might literally see the worms on an X-ray sometimes.
Fascinating. And a bit unsettling, definitely. And treatment for those stuck objects.
For boluses, management often involves trying to gently milk them along the bowel, maybe crush them internally if possible without opening the bowel, or if necessary, making an incision into the bowel to remove the object directly.
Okay. Moving on to the heavyweight champion of causes in Western countries, adhesions and bands.
Right, that's scar tissue. Typically forms after abdominal surgery. The force emphasizes these start forming remarkably quickly, like within hours of the operation.
Can surgeons do anything to stop them?
Well, they try. Good surgical technique, gentle handling of tissues, washing out the abdomen thoroughly, minimizing the use of things like gauze packs covering raw surfaces. These things help. But the source notes that despite many proposed substances or barrier materials designed to prevent adhesions, none have been convincingly proven to be highly effective in clinical practice. It's still a major challenge.
So the basics of good, careful surgery are still paramount.
Exactly. Adhesions can range from flimsy, thin strands that are easy to break to dense, thick sheets that are much harder to deal with. They most commonly affect the lower part of the small bowel, the ileum. Bands can also be present. These are sometimes congenital, meaning someone's born with them, or they can be acquired strings of tissue that can trap bowel.
Intussusception, the telescoping bowel, we often think of that in babies, don't we?
It is most common in infants, typically between 5 and 10 months old. The source suggests it might be related to swelling of lymph tissue in the bowel wall, called Peyer's patches. This swelling might be triggered by a viral infection or maybe changes in diet when they start weaning. This swollen patch might act as a lead point that gets pulled into the segment below by peristalsis.
Okay, so maybe triggered by something simple in babies.
Possibly. However, the source makes a really crucial distinction here. In older children, and especially in adults, intussusception is almost always caused by a definite pathological lead point.
Meaning there's something specific wrong.
Yes, something specific in the bowel wall that's being dragged forward like a polyp, a small pouch called a Meckel's diverticulum, or, quite commonly in adults, a tumor.
Ah, so it's much less likely to be spontaneous in adults and more a symptom of an underlying problem.
Precisely. You have to look for that lead point in adults. The source describes the anatomy. The inner part that telescopes is the intussusceptum, and the outer receiving part is the intussuscipiens. The most common type in children involves the ileum telescoping into the colon, ileocolic, while in adults it's more often colon into colon, colocolic. The risk of strangulation depends on how tightly it's folded and trapped, especially if it has to pass through the ileocecal valve.
And finally, volvulus, the twist.
This is where a loop of bowel twists around the mesentery, that stalk of tissue attaching it to the back of the abdomen and carrying its blood supply. The source notes that a twist of more than 180 degrees can block the lumen, and if it goes over 360 degrees, it often cuts off the blood supply, leading to that critical vascular compromise and ischemia.
Are there different kinds?
Yes, they distinguish between primary types, often due to congenital issues, like the gut not rotating into the correct position during fetal development, malrotation, and secondary types, where the twist happens around an acquired point, like an adhesion or even around a stoma site.
What are the specific types of volvulus mentioned in the source?
Okay, there's volvulus neonatorum in newborns.
Yeah.
Strongly linked to that mad rotation issue. It can be rapidly life-threatening, a true surgical emergency. Then there's sigmoid volvulus, which is the most common spontaneous type in adults. The source mentions interesting geographic differences.
Oh.
It's very common in some indigenous Black African populations, perhaps related to diet and anatomy, but less common to Europe or the USA. In Western countries, it's often seen in older, often institutionalized or debilitated patients who suffer from chronic constipation. Factors include having a long, floppy sigmoid colon and a narrow base where it attaches to the mesentery.
So anatomy and maybe even diet play a role there?
It seems so. They describe symptoms ranging from a sudden, severe onset, fulminant with rapid progression, to a more gradual pain and distension developing over days, indolent. There's also caecovolvulus, involving the caecum, the very first part of the large bowel. This often presents acutely with severe pain, and there's a high risk of ischemia. An interesting point, the caecum can sometimes end up in an unusual location in the abdomen on examination, which can be a clue.
Right.
And then there's the rare but dangerous compound volvulus, sometimes called ileosigmoid knotting, where a loop of small bowel actually twists around the sigmoid colon. Highly dangerous because it often causes gangrene in both the small bowel and the sigmoid loop.
Okay, wow. We've covered a multitude of causes, from the common to the rare. Now, how does a patient with intestinal obstruction actually look or feel? What are the signs doctors are looking for?
The source gives us a classic group of symptoms, often called the quartet of dynamic obstruction. These are the big four: abdominal pain, distension, vomiting, and absolute constipation.
Those are the main red flags, then.
Exactly. Though, as the source is careful to point out, how prominent each symptom is can vary a lot. It depends on where the obstruction is, high or low, how complete it is, how long it's been going on, and critically, whether there's ischemia or strangulation involved.
Let's break those down. Pain, what's typical?
Pain is usually the first symptom. It's typically sudden and severe, often described as colicky, meaning it comes and goes in waves, cramping pain. This corresponds to those periods of strong peristalsis trying to push against the blockage the location can give clues to. Pain around the umbilicus often suggests small bowel obstruction, while lower abdominal pain might point towards the large bowel.
And the source notes something counterintuitive about the pain, right? That it might lessen.
Yes, this is important. If the obstruction isn't ischemic, if the blood supply is okay and it just continues for several days, the colicky pain can actually lessen or even disappear.
What?
Because the bowel muscle above the block eventually tires out, it becomes fatigued and distended, and peristalsis weakens. However, and this is crucial, severe constant pain is a major warning sign. It strongly suggests strangulation might be happening, especially if that pain isn't controlled by typical opiate pain medication.
So worsening constant pain is bad. Less pain could mean the bowel is tiring out unless it's constant pain.
Precisely. Also, colicky pain is usually less prominent in patients who develop obstruction soon after surgery or in those with paralytic ileus where the bowel isn't contracting forcefully anyway.
What about vomiting?
The timing of vomiting is a good clue to the location of the blockage. With a high small bowel obstruction, vomiting starts early and can be profuse. With a blockage further down the small bowel or in the large bowel, it tends to happen later. And as the contents stagnate above the block and bacteria multiply, the character of the vomitus changes. It can become thick, brown, and foul-smelling, described as feculent, meaning it smells and looks like feces.
Pleasant distension, the abdominal swelling.
Distension, the swelling of the abdomen, is generally more pronounced the further down the small bowel the obstruction is located. In the large bowel, it's often a later feature. In thin patients, you might even see the loops of bowel visibly contracting under the skin during waves of colic visible peristalsis. Distension can sometimes be minimal or absent if the main problem is the blood supply to the mesentery being cut off quickly before significant backup occurs.
And absolute constipation, no passage of anything.
This is considered a cardinal feature of complete obstruction. The patient passes neither feces nor flatus, gas, total blockage. The source advises against giving enemas if you suspect complete obstruction, because it can empty the bowel below the block and make it seem like the patient isn't fully constipated, confusing the clinical picture.
But are there situations where you can have an obstruction but still pass something? Stool or gas?
Yes. The source lists important exceptions to the absolute constipation rule. In partial obstruction, some gas or even diarrhea might squeeze past the blockage. Other specific situations include a Richter's hernia, where only part of the bowel wall is trapped and obstructed, not the whole circumference, so the lumen isn't fully blocked. Early on in gallstone ileus, before a complete blockage. Or obstruction related to mesenteric vascular occlusion, where the bowel stops moving due to lack of blood supply before it completely blocks mechanically. Also, if there's a pelvic abscess irritating the rectum.
So absolute constipation points strongly to complete obstruction, but the lack of it doesn't rule out partial obstruction or some specific types. What other physical signs might doctors find?
Dehydration is common. Signs like dry mouth, reduced skin turgor, fast heart rate, especially with small bowel obstruction due to all that fluid loss we talked about. Electrolyte imbalances can occur, though the source notes low potassium isn't typical in simple obstruction. However, things like rising potassium, lactate, or changes in white blood cell count can be indicators of strangulation.
And fever.
Pyrexia, or fever, might suggest ischemia, perforation, or inflammation. Conversely, hypothermia, a low body temperature, can be a sign of septic shock in severe or neglected cases. On physical exam, abdominal tenderness is absolutely crucial to assess. Tenderness localized to one specific area strongly suggests impending or already established ischemia in that segment of bowel.
And if it's more widespread?
If the abdomen is diffusely tender, especially if it's rigid or board-like, what doctors call peritonism or frank peritonitis, inflammation of the abdominal lining, that's a very serious sign. It strongly suggests the bowel has died, infarction, or even ruptured perforation. The source specifically mentions that in suspected large bowel obstruction, it's vital to check the right lower abdomen carefully, the area of the cecum, because that's often the part most likely to perforate due to the high pressure in its thin wall.
And bowel sounds. You often hear about specific sounds doctors listen for.
Classically, in early dynamic obstruction, the bowel sounds can be high-pitched and frequent, sometimes described as tinkling or rushes, reflecting that vigorous peristalsis trying to push through the block. However, the source notes that in long-standing obstruction, or as strangulation develops, or in paralytic ileus, bowel sounds can become scanty or completely absent, a key point they make. Normal bowel sounds have a good negative predictive value. If the sounds seem normal, it makes significant obstruction much less likely.
Let's really underscore those signs of strangulation again. This is the absolute surgical emergency. What are the key things to look for?
Absolutely. The source summary box highlights the key clinical features that demand urgent action. First, constant severe pain. This is different from the intermittent colicky pain of simple obstruction. It doesn't let up. Second, tenderness with rigidity or peritonism on abdominal examination. That stiffness is a bad sign. And third, signs of shock like low blood pressure, fast heart rate, cool extremities. They stress that shock developing strongly suggests ischemia is present.
So constant pain, tenderness, rigidity, and shock are the triad for strangulation.
Yes. They add important nuances too. Pain is never completely absent if strangulation is impending or established. Even mild localized tenderness needs to be taken seriously and requires very frequent reevaluation. If the abdomen becomes generally tender and rigid, immediate surgery, laparotomy, is needed. And another point, if the pain doesn't get better despite adequate opiate pain relief, even without other obvious signs, strangulation should be highly suspected.
And for a trapped external hernia, you mentioned specific things to look for on the hernia itself.
Yes, the hernia lump will be tense, very tender to touch. You won't be able to push it back, and it's irreducible. It won't bulge out more when the patient coughs,
Yeah.
loss of cough impulse. And later on, the skin over it might become red or discolored, which is a late sign indicating ischemia in the trapped tissue underneath.
Moving to intussusception, the clinical features in children sound quite specific and, frankly, distressing.
They're very characteristic. The classic presentation in an infant is these sudden severe episodes of screaming pain where they draw their legs up towards their abdomen. They look pale during the attack. Then between these attacks, they might seem unusually pale, listless, or lethargic. Vomiting starts, often becoming vial-stained as the obstruction progresses. The stools are initially normal, but later they pass that characteristic mix of blood and mucus, which is vividly described as red currant jelly stool.
That's a very visual and memorable sign. Hard to miss.
It is. The source advises that examining the child between these painful episodes is often most fruitful, as they might relax slightly. The abdomen isn't usually distended early on. You might, in about 60% of cases, feel a firm, sausage-shaped lump somewhere in the abdomen. This lump tends to harden during the painful colic episodes. Another sign mentioned is Dance's sign, which is a feeling of emptiness in the right lower abdomen because the cecum has been pulled medially or upwards by the telescoping bowel.
And a rectal exam.
Might reveal the blood-stained mucus, or sometimes even the chip apex of the intussusception itself. If it's not treated, the child becomes dehydrated, the abdomen distends, and eventually peritonitis from gangrene sets in. The source does mention a rare natural cure where the affected bowel segment can slough off, but that's obviously not the goal and carries huge risks.
What about volvulus presentations? Do they vary?
Yes, small intestine volvulus can present variably, often with acute severe pain. For caecal volvulus, you often feel a drum-like tympanic swelling on examination, and as we said, the cecum might be felt in an unusual location, maybe higher up or more central than normal. Sigmoid volvulus typically starts with prominent progressive abdominal distension, often quite dramatic, along with that absolute constipation we discussed. Sometimes, rarely, you might even see the outline of the hugely dilated sigmoid colon through the abdominal wall.
Okay, so symptoms and physical exam give us lots of clues, but how do doctors confirm what's going on and pinpoint the location? Imaging must be absolutely key.
Absolutely. The starting point is usually plain abdominal x-rays, typically taken with the patient lying flat, supine. An upright view, or sometimes a lateral decubitus view lying on the side, might also be done, mainly to look for air fluid levels or free air under the diaphragm, suggesting perforation.
How do those plain x-rays help distinguish between a small bowel and a large bowel obstruction? What do they look for?
They look quite different when they're distended with gas and fluid because of their internal anatomy. The small bowel, specifically the jejunum, upper part, has folds called valvulae conniventes. These go all the way across the full width of the bowel lumen and are closely and regularly spaced. When dilated, they give a characteristic stacked look, sometimes called the ladder effect on the X-ray.
Okay, ladder effect for jejunum.
Right. The ileum, further down the small bowel, is more featureless internally. The large bowel, on the other hand, has folds called haustra. These are irregular, they don't go all the way across the full width, and they create indentations or sacculations that aren't directly opposite each other, so it looks more segmented or pouched. The cecum itself is usually seen as a rounded gas shadow in the right lower abdomen, if it's in its normal place.
So you're looking closely at the pattern of the internal folds and the dilated loops. What about air fluid levels?
The air fluid levels appear as gas rises above pooled fluid within the bowel loops. You see them best on upright or cross-sectional images. While a couple of small fluid levels can be normal in adults, like in the stomach or duodenal cap, numerous or prominent fluid levels, especially arranged in that ladder pattern in the small bowel, are a strong sign of obstruction or paralysis, Elias. Their number and location can sometimes give a clue about how high up or how complete the obstruction is in the small bowel.
The source also talks about using contrast liquid, not just looking at gas patterns.
Yes, a water-soluble contrast study can be very useful, particularly in managing suspected small bowel obstruction where there's no immediate suspicion of strangulation.
How does that help?
You give the patient the contrast liquid to drink or put it down the NG tube. Then you take follow-up x-rays. If that contrast reaches the large bowel, the colon, within 4 to 24 hours, the source says it's highly accurate, high sensitivity and specificity for predicting that the obstruction will resolve on its own without surgery. It tells you things are moving through.
And if it doesn't reach the colon?
If the contrast doesn't reach the colon within that time frame, about 90% of those patients will end up needing surgery. So it's a good predictor. The source also notes a potential therapeutic benefit. The contrast itself is hyperosmolar, meaning it draws fluid into the bowel, which might help dislodge a partial blockage or stimulate movement. Studies suggest it might reduce the need for surgery and shorten hospital stays in adhesive obstruction.
What about contrast for large bowel?
A limited contrast enema, given from below using water-soluble contrast, can help distinguish between a true mechanical large bowel obstruction and pseudo-obstruction, where the bowel is dilated but not physically blocked. But, and this is really critical, the source warns strongly that a barium follow-through study, where you drink barium, is absolutely contraindicated in acute obstruction.
Why is barium so bad here?
Because if the obstruction is complete, the barium will just sit above it. It can absorb water, become inspissated like cement, and make the blockage much, much worse, potentially converting a partial obstruction into a complete one that definitely needs surgery. So, water-soluble contrast is okay. Barium is a definite no-no in acute obstruction.
That's a really crucial point for listeners to understand. What about CT scans? They seem ubiquitous now.
CT scanning is now widely used and is highly accurate for confirming the presence of obstruction, identifying the location, and often figuring out the cause, like a tumor, adhesion, hernia, etc. It gives a fantastic anatomical overview.
So CT is the gold standard.
For diagnosis and locating the problem, yes, it's very powerful. However, the source is very clear on its main limitation: diagnosing strangulation or ischemia.
It can't tell if the bowel is dying.
Not reliably.
Yeah.
While CT can show some signs that might suggest ischemia, like reduced enhancement of the bowel wall when contrast is given intravenously, thickening of the wall, haziness in the surrounding fat, gas in the bowel wall or portal vein, a late sign, none of these are perfectly sensitive or specific. So the source reiterates that the diagnosis of strangulation remains primarily clinical. You still rely most heavily on the patient's symptoms, especially that constant pain, their physical exam findings, tenderness, rigidity, and maybe blood tests. CT helps confirm obstruction, but doesn't reliably rule out ischemia.
So even with these incredibly detailed scans, the doctor's hands-on assessment and listening to the patient are still paramount for spotting that emergency situation.
Exactly. The source emphasizes that point repeatedly. Clinical judgment remains key for strangulation. They also know that imaging like X-ray and CT will show gas and fluid accumulation in paralytic ileus and pseudo-obstruction too, but usually the pattern is more diffuse, involving both small and large bowel, and the clinical picture, lack of colicky pain may be a known cause for ileus, helps differentiate those from mechanical obstruction.
Are there specific imaging findings for intussusception or volvulus that are helpful?
Yes. For intussusception, plain X-rays might show general signs of obstruction, and in the common aleacolic type, often an absent gas shadow in the right lower abdomen where the cecum normally sits. Ultrasound is very sensitive, especially in children, and shows a characteristic layered appearance, often described as a target or donut sign on cross-section. CT is considered the most sensitive imaging overall, particularly in adults and older children. It shows a target-like mass with alternating layers of bowel wall, trapped mesenteric fat, and blood vessels visible inside the telescope segment.
Very visual signs.
Yeah.
And for volvulus?
Caecal volvulus on X-ray often shows the hugely dilated cecum, sometimes looking like a coffee bean, often displaced from its normal position into the upper abdomen or left side. A contrast enema might show a tapering twist where the contrast stops, looking like a bird's beak. CT is often the preferred imaging choice here as well for confirmation and assessing complications. Sigmoid volvulus typically shows a massively distended loop of sigmoid colon on plain X-ray, often forming an inverted U shape that rises diagonally across the abdomen from the pelvis. You might see two fluid levels within that single loop on an erect film. Volvulus neonatorum X-rays can be variable, sometimes showing signs of duodenal obstruction if that's involved, or sometimes even looking relatively gasless if strangulation has occurred quickly, causing fluid to fill the loops instead of gas.
All right, we've got a handle on what it is, the myriad causes, how it presents clinically, and how imaging helps nail down the diagnosis. Now, the critical part. How do we treat intestinal obstruction? What are the approaches?
The source outlines three main pillars of treatment for acute obstruction, things that need to happen pretty quickly. First, gastrointestinal drainage, usually with the nasogastric NG tube. Second, fluid and electrolyte replacement intravenously. And third, ultimately, relief of the obstruction itself, which often means surgery.
The first two sound like immediate stabilization steps, absolutely essential.
They are. You almost always start with these. An NG tube, like a Riles or Salem sump tube, is put down the nose into the stomach to suck out the accumulated fluid and gas from the stomach and upper bowel. This helps relieve the distension, which makes the patient more comfortable, reduces vomiting, and importantly, lowers the risk of them aspirating stomach contents into their lungs, which can cause serious pneumonia.
And the fluids.
Fluid and electrolyte replacement is vital because, as we discussed, these patients lose a lot of water and sodium into the bowel through vomiting and reduced intake. Doctors give intravenous fluids, often solutions like Hartmann's solution or normal saline, tailoring the amount and type based on the patient's vital signs, urine output, and blood tests. These two steps, NG drainage and IV fluids, are crucial before any potential surgery to get the patient as stable as possible, and they're usually continued afterwards as well.
Okay, stabilized. When is surgery necessary and how quickly does it need to happen?
The timing is absolutely key and depends heavily on the cause and, most importantly, whether strangulation is suspected. The source lists clear indications for early or immediate surgery. First, an obstructed external hernia, like an inguinal or femoral hernia. These have a very high risk of strangulation, so they generally need fixing right away. Second, any clinical signs suggesting intestinal strangulation, that constant pain, tenderness, shock we talked about. And third, obstruction in someone who hasn't had previous abdominal surgery, a virgin abdomen.
Why operate early on someone with no prior surgery?
Because the cause is less likely to be simple adhesions. It might be something inherently more dangerous, like an internal hernia, a tumor, or maybe even volvulus, which might need urgent attention. The historical saying mentioned in the source, "The sun shouldn't both rise and set on an unrelieved obstruction," really reflects that historical urgency driven by the fear of missing early strangulation before it becomes irreversible.
But what if there are no signs of strangulation? Is there more time?
Yes. If the obstruction seems complete based on symptoms, but there are absolutely no clinical or radiological signs suggesting the blood supply is cut off, you generally have a window of time, maybe 12 to 24 hours, to fully resuscitate the patient with IV fluids and correct any imbalances before operating. Get them in the best possible shape for surgery. And importantly, if the obstruction is thought to be due to adhesions from previous surgery, the most common cause but exceeded. The source notes that conservative management can often be tried first.
Meaning no immediate surgery.
Right. Keep the patient nil by mouth. Continue the IV fluids and the NG tube drainage and watch them very closely. Many adhesive obstructions will actually resolve on their own with this approach. The source suggests this conservative trial can go on for up to 72 hours, as long as there's no development of worrying signs suggesting strangulation.
72 hours? That seems quite long.
It requires very careful monitoring, regular examination, maybe repeat imaging, but it avoids surgery in a significant number of patients with adhesive obstruction.
Okay, so if surgery is needed, what happens then? What do the surgeons do?
If the cause isn't known precisely beforehand, surgeons typically make a midline incision down the abdomen to get good access and visibility. They carefully explore the bowel, starting usually from the collapsed section below the obstruction and working backwards to find the point of blockage. They identify the cause is an adhesion, a tumor, a twist. And most critically, they assess the viability of the bowel above the block. Is it still getting enough blood supply? Is it healthy pink? Or is it looking dusky or black?
How do they handle the swollen bowel? It must be difficult.
Very carefully. Distended bowel is fragile and prone to injury. Sometimes they can decompress the bowel during surgery by gently squeezing the contents back up the NG tube, or, more rarely now, using specialized needles or tubes to suck out the contents, though this carries risks of spillage and contamination. The actual procedure depends entirely on the cause found. It might involve simply dividing a single adhesive band, cutting out, resecting a segment of diseased bowel like a tumor or strangulated section, creating a bypass around an unresectable blockage, or sometimes just decompressing the bowel if that's all that's needed or possible. How do they actually decide if a segment of bowel is still viable, if it's going to survive, or if it needs to be removed? It's a crucial judgment call made during surgery. The source lists key factors they look for. The color, it should be pink or return to pink quickly after relieving the cause, not stay blue or black. The sheen, healthy bowel looks shiny, dead bowel looks dull. Whether there's visible peristalsis, muscle contractions in the wall, and whether the blood vessels in the mesentery supplying that segment are pulsating.
What if they're not sure? It looks borderline.
If it looks questionable, They might wrap the segment in warm, moist packs for about 10 minutes and then reassess. If it's still doubtful after that, the safest course is usually to resect it, to remove that segment.
Unless.
Unless removing it would be catastrophic, meaning it's so extensive that it would leave the patient with dangerously short bowel syndrome, which has its own severe long-term consequences. In that rare, difficult situation, they might have to leave questionable bowel in and hope for the best, maybe planning a second look operation 48 hours later to reassess viability.
What happens after they remove the segment? Do they always join the ends back together?
Ideally, yes. If a segment is removed, the goal is usually to rejoin the healthy ends, primary anastomosis. However, in certain situations, like if the patient is very unstable, in shock, if there's heavy contamination in the abdomen from perforation, or if the remaining bowel ends look unhealthy, the surgeon might decide it's safer not to join the ends immediately. Instead, they might bring one or both ends of the bowel out onto the abdominal surface as a stoma, like a colostomy or ileostomy. This diverts the fecal stream away from the healing area and avoids the risk of the joint leaking, which can be fatal. The stoma can often be reversed in a later operation when the patient is stable.
Speaking of adhesions, the source had specific advice for operating on those, right? Since they're so common.
Yes. Firstly, reiterating that initial conservative management fluids and G-tube is often tried first for up to 72 hours, provided there are no signs of strangulation. You monitor them very closely. If surgery is needed for adhesive obstruction, and they find many adhesions, the source advises trying to identify and divide only the single adhesion or band that is clearly causing the current obstruction, if possible.
Not divide everything.
No. Trying to take down all adhesions, extensive adhesiolysis, often just leads to more raw surfaces and encourages even more adhesions to form later, potentially causing future obstructions. So, targeted division is preferred. Also, any areas of the bowel wall that were clearly damaged or crushed by the constricting band should be carefully inspected and maybe repaired or oversewn to prevent late perforation. Laparoscopic surgery to divide adhesions, laparoscopic adhesiolysis, is possible, but is considered an advanced procedure requiring significant expertise.
How about treatment for intussusception, especially in children where it's common?
In infants and young children, after initial resuscitation with fluids, the first attempt is often non-operative reduction. This usually involves using an enema either with air or sometimes contrast liquid like barium or water-soluble contrast, though air is now more common given under fluoroscopic or ultrasound guidance.
How does the enema work?
The pressure from the enema pushes the telescope segment, the intussusceptum, back out of the receiving segment, the intussuscipiens. Success is confirmed if the air or contrast flows freely back into the terminal ileum, the end of the small bowel, and importantly, the child's symptoms rapidly resolve.
Does it always work?
Success rates are high in experienced centers, often over 80–90%. However, this non-operative reduction is not attempted if the child shows signs of peritonitis, suggesting perforation or dead bowel, shock, or if there's clear evidence of perforation on imaging, or if a pathological lead point is strongly suspected, as these are unlikely to be reduced by pressure alone and need surgery anyway.
What if it fails or isn't appropriate?
Then surgery is needed. Surgeons typically make a small transverse incision in the right lower abdomen. The key technique for reduction, emphasized in the source, is to gently squeeze the intussusception from the distal end, trying to milk it backwards, not pulling on the proximal bowel, as pulling can easily tear the fragile, swollen tissue. If the intussusception can't be reduced manually, or if the bowel is clearly non-viable, dead, or if a lead point, like a Meckel's diverticulum or polyp, is found, then the affected section of bowel is resected, and usually the ends are joined back together, primary anastomosis.
The source also briefly covers obstruction in newborns, doesn't it?
Yes, mentioning several congenital causes. A key one is intestinal atresia, where parts of the bowel tube simply didn't form properly or are completely blocked or narrowed. Duodenal atresia, in the first part of the small bowel, is most common, followed by jejunal atresias further down. Colonic atresia is rare. These babies often present very early, within the first day or two of life, with bilious green vomiting if the blockage is high up, beyond where bile enters, or abdominal distension if it's lower down. Surgery is required to fix the specific type of atresia found.
And meconium ileus, you mentioned it's linked to CF.
Yes, this is very strongly associated with cystic fibrosis. The source says it's present in almost all cases. The problem isn't a structural abnormality, but the baby's meconium, their first stool, is abnormally thick, sticky, and tenacious due to a lack of pancreatic enzymes, which are deficient in CF. This plugs up the terminal ileum.
How do they present?
These babies might fail to pass meconium, develop distension, and sometimes you can feel rubbery, lumpy loops of bowel filled with this thick meconium through the abdominal wall. X-rays might show dilated small bowel loops, sometimes with a bubbly or granular appearance, Neuhauser sign, but often without the typical air fluid levels seen in other obstructions because the meconium is so viscous.
How is it diagnosed and treated?
Diagnosis is often suspected clinically based on the presentation and maybe a family history of CF. It's confirmed with genetic testing for CF mutations or a sweat test, which shows high salt levels in CF. Treatment for uncomplicated cases, no perforation or volvulus, can often be non-surgical initially. They use a special hyperosmolar contrast enema, like gastrographin. This draws fluid into the bowel, helping to soften and dislodge the sticky meconium plugs. It needs careful monitoring and IV fluid support because it can cause dehydration. If the enema fails, or if there are complications like perforation or volvulus associated with it, then surgery is necessary to clear the blockage.
Okay, let's shift gears to treatment specifically for acute large bowel obstruction, often caused by cancer or diverticulitis in adults.
Right. First step, as we mentioned, is usually imaging, like CT or contrast enema, to confirm it's a true mechanical obstruction and exclude pseudo-obstruction. Surgery is usually necessary. The source emphasizes a key danger during surgery: the risk of the cecum rupturing if it's massively distended, especially during handling. The wall is thinnest there, particularly along the tenia coli, the longitudinal muscle bands.
What does the surgery involve? Does it depend on where the blockage is?
Yes, the surgical approach depends significantly on the location of the blockage in the colon and the patient's overall condition. For blockages in the right colon, cecum, ascending colon, or proximal transverse colon, the standard operation is usually removing that entire section, right? Hemicolectomy. The good news is that the ends, the terminal ileum, and the remaining transverse colon can often be safely rejoined, primary anastomosis, in the same operation, provided the patient is stable and the bowel looks healthy.
What about blockages further down on the left side?
For blockages in the left colon, distal transverse, descending, sigmoid, or rectum, management in the emergency setting is often more complex. This is partly due to the different blood supply and the fact that the bowel contents here are solid feces, making immediate anastomosis riskier if the bowel isn't properly cleaned out. If the patient is unstable, very frail, or if there's perforation or significant risk of the anastomosis leaking, the surgeon might opt for a staged approach. The most common is removing the block section, but not joining the ends immediately. Instead, they bring the upper end out as an end colostomy on the abdomen, Hartmann's procedure, and oversew the lower rectal stump.
So the patient has a stoma bag temporarily.
Yes. This diverts the feces, allows the patient to recover from the emergency, treats any infection, and then the bowel continuity can potentially be restored in a second, planned operation several months later by taking down the stoma and joining the ends. Alternatively, sometimes a loop colostomy might be created proximal to the blockage just to decompress things, with definitive surgery later.
Is there ever an option to join the ends immediately on the left side in an emergency?
It's sometimes done, especially if the bowel can be cleaned adequately during the operation, using techniques like on-table lavage, washing out the colon during surgery before anastomosis. But this is technically demanding and less common now. The source indicates immediate resection with primary anastomosis for left-sided obstruction is often feasible in experienced hands if conditions are favorable. But Hartmann's remains a very common and safe option, especially for less experienced surgeons or in difficult circumstances.
What about non-surgical options for large bowel blockage? You mentioned stenting.
Yes, for malignant large bowel obstruction, blockage caused by cancer, particularly on the left side, inserting a self-expanding metal stent, SEMS, through a colonoscope is an important option.
How does that work?
It's essentially a mesh tube that's placed across the blockage under endoscopic guidance. It then expands, propping open the narrowed area caused by the tumor, allowing stool and gas to pass through.
What are the advantages?
It can effectively relieve the obstruction without the need for major emergency surgery, and often avoids the need for a stoma, at least initially. The source notes it's associated with reduced mortality and morbidity compared to emergency surgery, especially in frail or elderly patients. It can be used as definitive palliation for patients with incurable cancer who aren't fit for surgery.
Can it be used if surgery is planned later?
Yes, that's another major role as a bridge to surgery. You place the stent to relieve the acute obstruction, which allows the patient's condition to be optimized, the bowel to decompress, and then you can perform a planned elective cancer resection operation a week or two later, often allowing for a primary anastomosis without a stoma, which is a major benefit. Guidelines support this approach, but it requires experienced operators and careful patient selection.
So stenting is a really valuable tool in the toolbox for malignant large bowel obstruction.
Definitely. It's changed practice significantly. If stenting isn't possible or fails, then surgical decompression, usually with the stoma, is the alternative.
How about treatment for volvulus? We talked about cacal and sigmoid volvulus.
Right. For Kegel volvulus, because the risk of ischemia is high, if the bowel looks dead or severely damaged at surgery, it requires resection, usually a right hemicolectomy.
Yep.
If it's still viable after untwisting detortion, surgeons have a choice. They can still resect it to prevent recurrence, or they can try to fix the cecum in place, cecopexy, or sometimes bringing it out as a temporary stoma cecostomy. However, the source notes that simple fixation, cecopexy, has a significant risk of the volvulus happening again later.
And sigmoid volvulus.
For sigmoid volvulus, if there's no sign of ischemia or perforation, the first step is often non-surgical: endoscopic decompression. This involves passing a flexible sigmoidoscope up into the twisted loop, untwisting it under direct vision, and then often leaving a soft rectal tube, flatus tube, in place for a day or two to keep it decompressed.
Does that fix it permanently?
It resolves the acute problem, but the recurrence rate after endoscopic decompression alone is very high because the underlying anatomical predisposition, long floppy sigmoid, is still there. So for patients who are fit for surgery after successful decompression, they should undergo an elective sigmoid colectomy, removing that segment of colon during the same hospital admission or soon after to prevent it from happening again.
What if the patient is too frail for elective surgery?
For elderly or very unfit patients who have recurrent volvulus after decompression, the options are more limited. Repeat decompression might be tried, or sometimes surgical options like resection if they can tolerate it, or procedures to fix the sigmoid colon in place, sigmoidopexy, or using 2 points of fixation might be considered, although fixation also carries a recurrence risk. If surgery is done in the emergency setting for sigmoid volvulus, for example, if decompression fails or ischemia is suspected, a Hartmann's procedure is often the safest option, especially for less experienced surgeons if resection is needed.
We focused mostly on acute sudden obstruction, but the source mentions chronic large bowel obstruction as well. How does that differ in presentation from the acute picture?
The symptoms tend to be much more gradual and less dramatic. Constipation is usually the first and most prominent symptom, often present for months or even years, becoming progressively worse over time. Distension develops later than constipation, but can eventually become quite profound. Pain also tends to occur later, often felt as an ache in the right lower abdomen when the cecum gets very stretched from the back pressure. Vomiting is usually a very late feature if it occurs at all, so significant dehydration isn't as common as an acute small bowel obstruction.
What kinds of things cause those chronic, slow-developing large bowel obstructions?
The source divides them into organic causes, meaning a physical blockage, and functional causes. Organic causes include things like chronic fecal impaction, benign strictures, perhaps from long-standing diverticular disease, ischemia, or radiation, narrowing at a previous surgical joint, anastomotic stenosis, or extrinsic masses like large pelvic tumors slowly compressing the bowel from the outside, and of course slow-growing cancers. Functional causes mean there's no physical block, but the bowel muscle or nerves aren't working correctly to propel things along. Examples include Hirschsprung's disease, a congenital absence of nerve cells, usually diagnosed in childhood, but milder forms can present later. Idiopathic megacolon, where the colon becomes massively dilated for unknown reasons, or chronic intestinal pseudo-obstruction.
How are these investigated and managed?
Investigation usually starts with plain x-rays, which might show massive colonic distension. Then, further tests like contrast enemas, CT scans, or colonoscopy are needed to identify the underlying cause and, crucially, to rule out a functional problem mimicking a mechanical block. Management depends on the cause. Organic causes generally require relieving the obstruction, often with surgery to deal with the stricture or mass, or potentially stenting for malignant causes. Functional cases are typically managed initially with conservative measures like laxatives, enemas, and sometimes colonoscopic decompression to remove impacted stool. But managing the underlying functional disorder is key long-term. The source notes there's still a risk of perforation in functional cases if the bowel becomes extremely distended, particularly the cecum.
Finally, let's circle back quickly to that other main category we started with. Adynamic obstruction. Paralytic ileus is the key example here, right?
Right. Paralytic ileus is essentially a failure of peristalsis, the gut's movement, not because something is physically blocking the way, but because the nerves controlling the bowel muscle, or the muscle itself, aren't working properly. It's a functional shutdown.
What are the key clinical differences from a mechanical obstruction?
You still get symptoms like abdominal distension, nausea and vomiting, and absolute constipation, no passage of stool or gas, because nothing is moving. But the key difference is there is typically no colicky pain,
Why no colic?
because the bowel isn't contracting forcefully against a blockage, it's just quiet and inactive. Bowel sounds are usually diminished or completely absent.
What causes the bowel to just stop working like that?
The most common cause the source mentions is after abdominal surgery, postoperative ileus. It's considered normal, almost expected, for the bowel to be sluggish for 24 to 72 hours after laparotomy. But it's considered a significant or prolonged ileus if bowel function, hearing sounds, passing flatus, hasn't returned after 72 hours.
What makes it last longer sometimes?
Prolonged postoperative ileus can be due to factors like excessive handling of the bowel during surgery, electrolyte imbalances, especially low potassium, low protein levels, certain medications like opiates, or complications like an intra-abdominal infection or abscess. Other causes of ileus, unrelated to surgery, include widespread infection, sepsis, metabolic problems like kidney failure, uremia, or severe electrolyte disturbances, hypokalemia, or sometimes reflexively from injuries elsewhere in the body, like spinal fractures or retroperitoneal hemorrhage.
So the signs are similar to obstruction in some ways, distension, vomiting, constipation, but the key differences are that lack of colicky pain and typically absent bowel sounds.
Exactly. X-rays show gas-filled loops throughout both the small and large bowel, often with multiple scattered air fluid levels, but usually without that single clear transition point you might see in mechanical obstruction.
How is paralytic ileus managed?
Management is primarily supportive while you wait for the bowel to wake up. This involves keeping the patient nilled by mouth, continuing IV fluids to maintain hydration and electrolyte balance, and usually using an NG tube for decompression to prevent vomiting and further distension. The source explicitly states there's no convincing evidence that prokinetic drugs medications intended to stimulate gut movement like metoclopramide are helpful in routine postoperative ileus. The focus is on treating the underlying cause if there is one, like infection, correcting metabolic issues, and allowing time for recovery. Enhanced recovery after surgery, ERS, protocols aim to minimize factors that contribute to ileus, like early feeding and mobilization.
What if it goes on for a long time?
If the ileus is prolonged, especially after surgery, doctors need to consider other possibilities. A CT scan might be done to look for an underlying complication, like an abscess, or even a missed early postoperative mechanical obstruction, which can be very hard to distinguish clinically from prolonged ileus. Deciding when or if to reoperate for suspected mechanical obstruction in the context of prolonged postoperative ileus is often a very difficult clinical judgment call.
And that final adynamic type mentioned briefly, pseudo-obstruction. What's that?
Pseudoobstruction is a relatively rare condition where the bowel, usually the colon, behaves as if there's a mechanical obstruction. It becomes significantly dilated, and the patient has symptoms of obstruction. But when investigated, there's no physical blockage found and no acute intra-abdominal disease, like peritonitis or ischemia, causing it.
So it looks like a blockage, but isn't.
Exactly. It's thought to be due to a problem with the nerves or muscles controlling bowel motility, often associated with underlying chronic systemic diseases, neurological conditions, or certain medications. There's a chronic small intestinal form, which often presents with recurrent episodes of subacute obstruction and is a diagnosis of exclusion. More acutely, there's acute colonic pseudoobstruction, sometimes called Ogilvie syndrome. This typically presents just like an acute large bowel obstruction, often with marked distension, particularly the cecum, which carries a significant risk of perforation if the dilation becomes extreme.
So it needs urgent attention.
Yes, it requires urgent investigation, usually with a water-soluble contrast enema or CT scan, to absolutely rule out a true mechanical blockage before concluding its pseudo-obstruction. Management then focuses on decompression, often colonoscopically, and addressing any underlying factors.
Wow. That was a truly comprehensive tour through a really complex area. We've covered everything from, well, hairballs and gallstones getting stuck, to the dangers of twists and scar tissue, to the bowel just deciding to stop working, all pulled from this detailed source.
Indeed. It really underscores, doesn't it, how many different things can interrupt such a fundamental process as digestion, and how the body responds in various ways. And it highlights how crucial seemingly small clinical signs could be the type of pain the patient describes. The character of the bowel sounds the doctor hears, the subtle patterns on an X-ray or CT in piecing together exactly what's happening inside.
Exactly. It really is like a detective story sometimes, isn't it? Where the clues come from the patient's story, the physical exam, and the images, all leading towards a diagnosis and a plan.
It is. And perhaps it leaves you, the listener, with an appreciation for just how finely tuned and, in some ways, vulnerable our internal systems are. How quickly things can go seriously wrong when that delicate balance of movement and absorption is disrupted.
A thought-provoking note to end on, for sure. That wraps up this deep dive into the complex world of intestinal obstruction, guided by Bailey and Love. We hope you found it illuminating.